with marked obesity. They are so fat like that, like this boy and his sister. Another baby with another child with marked obesity and short stature. This child actually is 15 years old. Another child showing marked obesity and short stature, he's 9 years old, with large moon face and polydactyly. These are 6 fingers, and there is a wide variety with short, plumpy hands like that. And sometimes the polydactyly emerges from the side of the little finger like this, or maybe a rudimentary finger, and this is the finger of the father, the same thing. And sometimes the polydactyly is actually fused with a little finger, and we call it syndactyly, and this is a bony syndactyly. And also polydactyly of the foot. I'm sorry for this dirty feet, because this is actually the quality of my patients in Alexandria University. They are quite poor. So polydactyly of the feet, and sometimes it emerges like a V-shaped pattern like that from the little finger, together with a short, plumpy, square feet like that. Again, these are square feet, and this is marked short and very short fingers. So there is a variety of polydactyly, syndactyly that may be observed. What about the dermatological diseases, skin diseases? What is the most common skin diseases that may be affected, maybe have congenital cataract? Like cocaine syndrome. Cocaine syndrome, they look very old. The babies are very old, as if they are senile. See with the wrinkles here in the face. And there is, when they are grown up, there is marked atrophy of the fat, and actually atrophy of the fat around the eye. And you see these are the sunken eyes, with skeletal abnormalities and bone abnormalities, and they usually have dislocations in the hips, in the hip joints, and abnormalities in the long bones, together with hypersensitivity of the skin. And there is actually, you cannot differentiate them from xeroderma pigmentosa. And this is a child with cocaine syndrome after surgery with aphakic spectacles. Premature infants may present with congenital cataract. If they are very young, like that, with a low birth weight, maybe less than 1,500 grams, or they are born less than 7 months, you may observe congenital cataract after they are out from the incubators, or when you get them from the incubators to the clinic in order to perform laser if they have a sort of retinopathy of prematurity. This laser actually that is applied to the retina may be teratogenic and may cause complicated cataract in such infants. Or the cataract actually is seen as a sequelae, as a complication of retinopathy of prematurity when we have a retinal detachment in stage 5 retinopathy of prematurity. Cerebral palsy, children born with congenital cataract may be affected with cerebral palsy. This is the child when he was 4 years old after performing congenital cataract. This is another child with cerebral palsy. This child now is 6 years and his brother is just 4. You can see the difference here. Cerebral oculofacial skeletal syndrome, a very common syndrome which is Cox syndrome. When to suspect? You have cerebral, there is mental retardation. Ocular, congenital cataract. Facial, there is abnormal large bat ears. It looks like a bat here. Can you see these are the everted ears like that? And also abnormal indentation. Skeletal, they are very short and stunted rod. This child is 9 years old. Another child with Cox syndrome, can you see the bat ears here? And the abnormal indentation and very short stature. Hallermann-Streiff-François syndrome. This is very common to present with congenital cataract, and here a child with aphakia. They have a very long beak nose. We call it, it is due to atrophy of the cartilage. Beak nose. Parrot beak nose, لا زي المناخير بتاع البغبغان. And there is small mandibles, microgonatlia here, and low set ears. This is with low set ears, and there is a frontal bossing. And areas of loss of hair, areas of alopecia, high arched palate, and 95% of them have congenital cataract. Congenital cataract may be associated with other congenital ocular abnormalities, as for example, glaucoma, congenital glaucoma, or microphthalmia, and here another eye with microphthalmus. But sometimes the microphthalmus is so severe that you cannot treat the cataract. But we go for cataract surgery in these children, even if the corneal diameter is 7 millimeters. It may be associated with undilatable pupil, atrophy of the sphincter papillae, or maybe persistent papillary membranes like that, or maybe associated with iris coloboma. We know that the typical iris coloboma is down and nasal. However, with congenital cataract, it may be variable. It may be atypical like that. It may be up and temporal. It may be asymmetrical in both eyes, or may be extensive, as in these cases. Congenital cataract may be associated with total absence of the iris, and this is called aniridia. It may be associated with Peters anomaly. And what is Peters anomaly? It is a central corneal opacity, like that. Attached to it is the iris, together with anterior polar opacity. And there is adhesions between this central opacity and the periphery of the iris. Also, congenital cataract may be associated with part of the lens missing here. And can you see this is the equator of the lens? This is lens coloboma with permanent ciliary processes, and these are the zonules. It may be associated with Marfan syndrome, and usually the patients are very long, like their parents here, with a wide variety of subluxation of the lens and extensive damage of the vitreous that may be associated with vitreous retinopathy that predispose to retinal detachment after surgery. And the zonules are usually elongated and sometimes disrupted. May be associated with microspherophakia, another abnormality of the lens in the shape and size, the lens being small and spherical, like that, like for example, Weimar-Kizani syndrome. You see this patient in the same age of the doctor. She's 26 years old and the patient is 26 years. So there is marked short stature in Weimar-Kizani. This is again, they are the same age, small hands, square hands, short clubbed fingers, and small square feet. And the microspherophakia may dislocate into the anterior chamber, damaging the cornea or causing secondary glaucoma, or may be dislocated into the posterior segment, causing retinal detachment or joint retinal taps. Congenital hydrocephalus may be associated with congenital cataract, so all babies with hydrocephalus should be examined for lens opacities. Persistent papillary membranes, which is remnants of tunica vasculosa lentis, may be associated with congenital cataract. It may be faint or may be extensive, like these membranes. And maybe these membranes with the cataract may be associated with lens coloboma or even aniridia. Abnormality of the vitreous, which is the persistence of hyaloid artery, is persistent fetal vasculature or persistent hypoplastic primary vitreous, which is the hyaloid artery extending from the disc to the back surface of the lens. It may be thin, like that, or may be thick. The retrolental fibroplasia may be thin or may be thick. The eye may be small or there may be severe microphthalmia. So not all cases of persistent hypoplastic primary vitreous we can go for surgery. It may be extensive like this, mimicking even retinoblastoma. You may suspect that this is a case of cancer, and sometimes associated with tractional retinal detachment. If only the posterior part is persistent, this is called persistent Burmester papilla. Or if the anterior part is only present, and we call this Mittendorf spot. So any part of the hyaloid artery, whether the total persistence of the artery or the posterior part or the anterior part, it gives you the different types. And then we said maybe associated with small eyes. this is microphthalmia, that sometimes is so severe and inoperable, we cannot offer surgery in such eyes. And in some cases, like this child, the lens may be either cataractous or not. The anterior chamber may be of normal depth or may be shallow, because they are usually associated with bulging of the anterior capsule, what is called anterior lenticonus, lenticulates, and usually associated with membranes behind the lens, and these membranes are vascularized, that show minimal vascularization or may show extensive vascularization, and this necessitating diathermy during cataract surgery. And also may be associated with marked decrease of central pulling of the ciliary processes. These are the ciliary processes that are pulled. So you should be prepared during cataract surgery to face any of these problems. Finally, the morphological types of cataract. In children, we can have the nuclear cataract, which is actually persistence of opacification of the embryonic or the fetal nucleus, and it may show different varieties. It may be square like that, triangular or feathery, or like a star shape, or mushroom shape like that. Lamellar cataract, the discal opacity, if you cut section, it's just taking a lamellar part, enclosing in between clear cortex. And these are different varieties of lamellar cataract. In children, wedge-shaped cataract, subcapsular cataract, which is probably due to trauma or complicated to drugs. In the periphery of the lens, coronary cataract, cortical spoke-like cataract, involving the sutures of the lens, and this is sutural cataract, involving the cortical cataract, and sometimes associated with calcification, commonly associated with calcifications, dots all over the lens. This is a blue dot or white dot cataract, and sometimes we call it ant egg cataract, and here seen against red reflex. If it is so severe like that, we call it punctate cataract. Flower or star-shaped cataract like that is a rosette-shaped cataract, and usually complicating trauma, involving the anterior capsule, anterior polar cataract, in the anterior pole of the lens, like that, and here seen against red reflex, and here with magnification, sometimes associated with papillary membranes. It may be small and tiny like this, or it may be large. And sometimes associated with other types of morphological types of cataract, and sometimes protruding into the anterior chamber, causing what is called pyramidal cataract, another eye here showing pyramidal cataract, and these are all varieties of anterior polar cataract, and sometimes associated with marked opacification of the anterior capsule, adherent to the iris, or adherent to the back surface of the cornea as a part of AC dysgenesis. Can you see here the anterior polar cataract attached to the back surface of the cornea, and here marked actually bowing and curving of the lens. Central opacity here we cannot judge, but if you look here, it is related to the posterior pole of the lens, so another type is posterior polar cataract. The posterior polar cataract may be small or may be large, may be central or may be paracentral, may be flat or may be protruding into the lens with calcification like this, and may be associated with spokes giving a star-shaped opacity like this. Posterior subcapsular cataract, which is usually complicated to trauma or drugs. Total opacification of the lens, which is called total cataract, when it imbibes water and there is shallowing of the anterior chamber, intumescent cataract, and whereas trauma, congenital or maybe defect or a trauma may cause damage to the posterior capsule, and there is partial absorption of the lens matter, where the anterior and posterior capsule come opposed to each other, leading to what is called membranous cataract. And finally, we should when to go for investigations. These are, we took the morphological types, the etiological types, and the pathogenesis. If we are suspecting galactosemia, we should look for reducing substance to see the galactokinase deficiency. If we find aminoaciduria, we should suspect Lewy syndrome. If we see blood in the urine, hematuria or proteinuria, we should suspect for Alport syndrome. And concerning the blood tests, erythrocytes enzymes, again, to diagnose galactokinase deficiency, glucose level in order to diagnose the hypo or hyperglycemia, which cause congenital cataract. If we suspect torch, we should go for torch titr. And if we suspect hypoparathyroidism, we should see the calcium and phosphorus level. And thank you for the first part of the lecture. We'll have a break 5 minutes.